All right. Hello and welcome, everyone. Thank you for joining us. I'm your host, McKenna Campbell, and I would just like to welcome you to our event tonight. It is a discussion on Exquisite Moments of Sorrow and Grace by Kenneth Weinberg, MD. Throughout this event, we ask you to hold your questions until the end. We will have a Q&A. ACS is an international association of healthcare professionals on the forefront of cannabinoid medicine. Founded by physicians, ACS is uniquely positioned to advocate for the highest standards in the practice of cannabis medicine. We are an advocacy organization striving to guide lawmakers and regulators at every level of cannabis control. Next slide, please. We also prioritize inclusivity and value having members from all walks of life, which motivates us to provide donate what you can memberships to qualifying groups. Additionally, student memberships are free. Please contact us directly if you have any questions about how you can get involved. On to the next slide. Let's see. On this next slide, you can see there are many benefits to joining ACS. For all of ACS's constituents, we provide evidence and experience-based education and resources to support the premise that cannabis should be treated as a medicine. Certainly feel welcome to reach out to us with any questions about membership opportunities. And for our student leaders, we encourage you to learn more about our Student Ambassador program. And the next slide. Thank you. So again, ACS is a nonprofit organization, so we do rely on donations to continue our work. We appreciate any level of giving, and you can support us directly through the QR code or website link as listed in the slide. And then if we maybe can put that in the chat, that would be great. And then yes, now introducing Dr. Kenneth Weinberg. He is a three-time board certified emergency medicine and medical marijuana physician. After finishing a residency in internal medicine, Dr. Weinberg created a fellowship in psychoneuroimmunology at the Manhattan VA, then trained in emergency medicine at Bellevue and NYU Langone Hospital. He has practiced emergency and urgent care medicine for over 3 decades. When New York State's Compassionate Care Act was passed in January of 2016, he founded Cannabis Doctors of New York. The advocacy, education, as well as cannabis research are also carried out in his role as a member of the Medicinal Cannabis Work Group at Northwell Health. Dr. Weinberg has treated thousands of patients with diseases across the spectrum of conditions. He is a cannabis advocate and an emerging thought leader who has lectured on the benefits of cannabis throughout the state, met with elected officials to promote its use, and been featured in various publications and on television. In addition, he is a published writer with a blog, Bedside Manners, on Psychology Today. His book, Exquisite Moments of Sorrow and Grace, is now available for purchase at Amazon and other online distributors. And with that, I'm excited to pass it on to Dr. Weinberg himself, and we get to hear a little more from him. Thanks so much for joining us.
Thank you so much, McKenna. And thank you, Kelsey, and Jordan, who I met, God, 8 or 9 years ago at the first cannabis research conference in, in Pueblo, Colorado, with the world-renowned Raphael Mechoulam. That was just fabulous, really wonderful event for several days. So I'm so glad, Jordan, that we're back in touch. And thank you for having me here to read my book. I'm going to read 3 or 4 stories, and then happy to talk about all of this. Hopefully, this will provoke people. And as McKenna said, I've been a doctor for 45 years. My father and grandfather were also physicians, and I've had a very circuitous route that got me to where I am now, which included quitting that fellowship in psychoneuroimmunology because I was trying to do a project to treat AIDS patients with acupuncture. And when I went in 1984, and I went to sign up the first patients, and one of the infectious disease doctors was outraged that I was going to be treating his AIDS patients with acupuncture. And my boss didn't support me. I quit. I needed a job, and I started working at Bellevue, and this at the ER in the ER at Bellevue, and that's where I started writing stories. So I accumulated about 25 stories over the years, and some of which have been published. And this is really a memoir of my backstory, including, for example, my youngest brother and I spent 2 years in medical school in Mexico. So I write all about that lunacy. And growing up with the family that I did, and we wove it together with these stories. So without further ado, I'll read some of my ER and urgent care stories. The first one is called Wind Tunnel. Working the ER is an assault on the senses. The sound of an ill, frightened infant screaming uncontrollably as she rolls in on the ambulance stretcher. The sight of a deep scalp wound, skull exposed stark white against the red and gray splotches of torn flesh. The feel of an abscess filled with pus and ready to burst, or the smell of hemorrhagic stool passed by the alcoholic whose stomach ulcer is oozing blood, all waft and commingle as the workday unfolds. Fortunately, most of the time, these sensory attacks percolate just below the surface, not affecting one's concentration and workflow, but sometimes, unexpectedly, they burst into consciousness, triggering such strong emotional responses that they bring things to a grinding halt. After working 15 years as a full-time emergency physician, I thought that I'd become inured to these visceral attacks, no matter how strong. I believed I'd seen, felt, or smelled it all. One hectic winter afternoon, I was proven wrong. It started subtly at first, something nearly subliminal. Then a particularly foul and unfamiliar odor erupted, permeating the entire ER. It seemed to be emanating from a new arrival who just meandered past us. I had finished sewing a laceration and was walking back to my desk when this occurred. Ken, why don't you finish your charting on that patient's laceration? Suggested Margie, my physician's assistant. I'll go find out what this is all about. Margie had worked with me for several years. She was a real dynamo, and before I could even turn around, she had run off like a hound on the scent of a quarry, her nose leading her to a cubicle in the back of the ER. 10 minutes later, she returned. The edges of her mouth were curled down, and the skin on her forehead was wrinkled. I need help with you. I need your help with this one, Margie said, as she shook her head slowly back and forth. What's a scoop? I asked, curiosity and repugnance swirling around in my brain. Patient's last name is Y. Her husband brought her here and insisted that she come today. She is the most amazing tumor I've ever seen. After examining her, I recommended that she be admitted. She agreed, but freaked when I mentioned surgery, and now she's balking at even staying in the hospital. As the attending physician in charge, it was now my turn to visit Mrs. Y. Walking back to her cubicle, I recalled prior cases where a patient would clearly be ill to my clinical eye, but would refuse to recognize the seriousness of the problem, sometimes angrily challenging my diagnosis and treatment recommendations. I thought of one man I'd seen recently who'd been experiencing several hours of chest pain at home. He'd finally been convinced by his wife to come to the hospital, and when I saw him, he was pale, sweating profusely, clearly uncomfortable as he sat on his stretcher. I'd gotten an EKG, then told him gently but firmly that he was having a heart attack, and that we needed to act right then and there to prevent any further damage to his heart. Before I finished my sentence, he'd pulled off the cardiac electrodes, jumped from the stretcher, and bolted out of the ER, running past me, the nurse, and his astonished wife. 5 minutes later, he'd been brought back in from the hospital parking lot in cardiac arrest. I guessed, per Margie's observation and my own olfactory response, that Mrs. Y's condition had to have its own extreme yet similar sense of urgency, tinged with that same lack of acceptance. That she would contemplate leaving the ER without treatment for this seemed evidence of either dementia, psychosis, or deep denial. I considered these possibilities and a strategy I could use to convince her to stay while I walked back to the room. As I entered the cubicle, I first saw Mr. Y, wringing his hands, pacing, eyebrows arched. By contrast, his wife was sitting calmly in a chair, harlequin reading glasses perched on the bridge of her nose, perusing a lady's home journal. Her voice was light, almost bouncy. Thank you for coming back here, doctor. Margie said you'd give me your opinion on how I should proceed. We need help bad, Doc, interjected the husband. He stared directly into my face, eyes open wide in frustration. I looked again at Mrs. Y. She was an elderly woman, missing most of her teeth, yet stylishly dressed and speaking with what struck me as aristocratic assurance. Her contradictions were as evident as her medical condition. She sat, exuding an air of faded elegance, as well as a skunk-like fragrance I'd never before encountered. It arose from a tumor on the right side of her head, as large as the head itself. Mrs. Y, I began, trying as best I could to hide my incredulity. How long have you had this growth on your scalp? Oh, about a year or two, I think, she responded sweetly. I tried to imagine how she and her husband had been able to tolerate this unbelievable invader of their space for any period. It was a tremendous mass, well covered by skin and patches of hair, its weight causing her head to list a bit to starboard. Despite having left her scalp largely intact, the tumor was oozing a yellowish viscous liquid from the several rents it had obviously caused in the dermis, as it grew beyond even that pliable tissue's ability to expand. I looked from Mrs. Y back to her husband. He appeared to be in his late 70s, with attire and a demeanor that conveyed a sense of command. He was wearing a houndstooth jacket and rep tie, had on a Rolex watch and manicured nails. I marveled at his apparent tolerance of his wife's persistence in not dealing with this. I thought again of the man having the heart attack and a few other extreme cases of denial I'd experienced before, but those cases at least had some nuanced subtlety, enabling me to understand how the patient and family could have refused to acknowledge the problem. I could see no nuancing the severity of Mrs. Y's issue. I clearly had to convince her of the need for immediate and aggressive treatment. Breathing through my mouth as a shield from the smell, I continued my conversation, trying to mix authority with compassion. I understand how difficult this is for you. The problems and fear the growth of this tumor must have caused, I said. The good thing is that surgery will take care of it. I paused, but it really does have to be taken care of today. Thank you, said the husband. It has been awful for both of us. He took a deep breath, I knew not how, and exhaled slowly. Doctor, Mrs. Y said, I'm so afraid of the surgery. Won't it be very painful? No, they'll put you to sleep, and when you wake up, it'll be gone, done with. I paused once more. You've been extremely lucky that this thing hasn't burst or given you blood poisoning. I hope that stressing this would be the ultimate motivation, forcing her to make the decision to no longer live with this alien co-occupier of her head. She sat silently for several moments, and I watched as her gaze seemed to turn inward with concern and anxiety, and then outward to me in reluctant resolve. Forcing a smile, she finally spoke. Okay, I know you're right. Would you please notify my doctor? I want him to get me the best surgeon in the hospital if I'm going to go through with this. I walked from her room to call John M., her primary care physician. On my way to the phone, I realized that I just learned something new about the boundaries of denial. I have Mrs. Y in the ER, I said to John when he came on the line. She's got a rather large tumor on the side of her head. Is her husband with her? John asked. Absolutely. I doubt he'd be here if he hadn't persisted and brought her in, I replied. Why do you ask? Well, it's kind of ironic. The first time I ever took care of him, John answered, he came into my office wearing a strange hat, very full at the top. The hat hid several tumors the size of golf balls on his head. John started chuckling and seemed to be waiting for my amused response. John, I parried back, this one's much larger than a golf ball. My God, John responded after a pause. I always assumed she had a strange hairdo. Every time she'd come into the office with her husband, we all thought she looked as if she'd been in a wind tunnel and was covering her hair with a scarf. Now it was my turn to pause. I feel like I could hear the requisite brum bum bum of the drum beat after a vaudeville punchline. There was no wind tunnel, John. I can assure you of that, I answered. She said she wants you to recommend the best surgeon in the hospital for her. 3 days later, I walked upstairs from the ER and went to visit Mrs. Y, who was now recovering from the surgery she'd had not long after I'd last seen her. In the operating room that day, they'd successfully removed a benign 20-pound tumor from her scalp. She was making an excellent recovery. As I peered into the room, I found her sitting in bed, watching TV. Bandages covered all of her head except the face. Dr. Weinberg, she said, smiling, as she noticed me in the doorway. Please come in. She extended her hand and brought me next to her. I have to thank you for your firmness and the way you spoke to me the other day. I don't think I would have gone through with this if not for you. I'm happy your husband was able to get you to come in. He deserves a lot of credit as well, I responded. Oh no, he actually wasn't the one who convinced me, she paused. You know, that day was our 50th anniversary. We were in a Hertz office getting a car to drive upstate to celebrate. The man behind the counter forced me to come in, refused to rent us a car. She paused and laughed. Can you believe that? At that moment, the image of her, scarf strategically placed, pus and stench exuding from her scalp, maneuvering her way into a rental car and heading off up the Taconic State Parkway with her husband at the wheel, burst into my brain. I thought about the wind tunnel, the depth of her and her husband's denial, and her husband's own tumors, and realized what a debt of gratitude we all owed to the agent at Hertz Rent-A-Car. Okay, now change a little bit. This one also has wind. This is the winds of spring. One hectic Friday afternoon in early spring, I approached the stretcher of my next patient and noticed he had already been hooked up to the cardiac monitor. In a busy ER like ours, that was a sign that when the nurse had brought him in from triage, she'd had some concerns about his status, though not enough to have immediately interrupted me and taken me over to see him. Glancing at the heart machine, I could see that his pulse rate was a normal 70 beats per minute. I looked at the patient as the monitor beeped regularly in the background and did a rapid evaluation to see just how he appeared. While he was obese and had a depressed, listless look on his face, he seemed to be resting comfortably on the stretcher. My impression was that he didn't seem ill, nor could I tell why he had been put on the monitor. As I looked at the triage notes, I saw that he was 55 years old, and from his name, his features, and his accent, I guessed he was from the Middle East. The notes also showed that his blood pressure had been slightly low when he came in, though it had normalized when I saw him, and he had a low-grade fever. As he spoke, he told me the reason he had shown up that day. I've been feeling a bit weak for the last day, not a lot of energy. My appetite is okay, but I just can't seem to get moving, feel a bit dizzy. As I examined him, I was struck by his flat, sorrowful affect more than anything on his physical examination. Weak and dizzy is one of the ER practitioner's most hated phrases. It can be heard from any patient with an impending stroke, sepsis, dangerously low sodium or potassium, to the hysterical, anxious somaticizer. My patient now seemed fine, but there was that initial low blood pressure and low-grade fever I had to consider. I checked his blood pressure again and found it to be 80 over 65, low, especially for a 200-pound plus man. I felt like he probably had a viral illness and some dehydration, so I decided to put in an IV, draw some routine blood tests, and watch him for the next few hours. While walking to my desk to write the orders on him, I noticed that Alan Felson, that day's on-call physician, was sitting in the ER talking to one of the nurses. Efficiency and timing are so important in keeping the flow in the ER as smooth as possible, so I walked over and discussed this patient with Alan. I knew he would want to know about the patient sooner rather than later to make his own workflow efficient as well. After our conversation, Alan obligingly went to see the patient as I sat writing orders. He came back and said he had decided to admit the patient for observation. The rest of the afternoon took on its typical frantic crescendo pace, and knowing that Alan was caring for this patient now, by the time I left at 7 p.m., my weak and dizzy patient had been lost to me in the rush of later events. I was off for the weekend, and Ona, Georgia, and I drove straight up to Ithaca to stay with my brother Neil and his family when I left work. The next morning, I was sitting on the deck of Neil's home in the woods, drinking my coffee and casually reading the New York Times. I happened to notice a small item tucked in the back of the Metro section. It talked about two patients who had been admitted late Friday to the teaching hospital located near the one I work at. Their diagnosis was botulism. I knew immediately it was my patient. But who was the other one? Botulism? What did I miss? Were they still alive? As soon as I could, I called Alan. I was desperate to know how they had made the diagnosis and what had subsequently transpired. And I was upset with myself for missing it. I did not, however, expect to hear what Alan had to say. It turned out that my patient's blood pressure never came up in the emergency room, despite multiple interventions, and it became clear that the patient needed an ICU bed. Our hospital's critical care beds were all filled, so Alan transferred this patient and his wife, who would come in later with the same symptoms, to the teaching hospital where he also had admitting privileges. Early the next Saturday morning, Alan was making rounds in the ICU with his medical resident. As they discussed this particular case, the resident, a Coptic Christian from Egypt, realized that this patient was an Egyptian Copt as well. He immediately told Alan about a ritual that was widespread in Egypt and had been brought to the United States by the Coptic community here. It was known as Sham el-Nasim, loosely translated as the winds of spring. This was a practice that was celebrated at the time of Passover and Easter, and historically predated those two festivals. It called for the burial of fish that were wrapped in paper in the earth. After 2 weeks, the fish were unearthed and eaten. In the age of saran wrap, however, the fish now were sealed in that airtight wrapping, creating the perfect environment for the growth of Clostridium botulinum. This is a bacterium that only develops when contained in a space that has no oxygen and that causes botulism. As the resident described further details to Alan, he learned that every springtime in Cairo, hundreds of people become very ill or died of this practice. Alan now realized this practice had surfaced in the United States, and through a serendipitous and fortuitous set of circumstances had landed these two patients in his care. Because of the semi-indolent course of their illness, Alan was able to begin treatment quickly enough to save both of their lives, and through his subsequent extensive research, educated me on this once ancient and ongoing disturbing practice. 3 years later, once again in springtime, I was on duty in the ER. As I approached the bedside of my next patient, I recognized the same man. Despite his nearly fatal earlier episode, he had apparently continued his religious practice. And now he had come in once more with the same ingestion, same time of year, and same symptoms. I was flabbergasted and couldn't believe that despite his prior event, he'd apparently not understood what happened or was such a fervent believer that his faith overruled the potential risk to his life. I kept my mouth shut and began the treatment I now knew he needed. We quickly admitted him to our ICU so we could bring him back from the brink one more time. There's a postscript to this story that Alan told me, which is it turned out, and people know what myasthenia gravis is, he had been diagnosed in our ER with myasthenia gravis by two neurologists. And the treatment for it did not exist, it turns out, at our hospital. So he was transferred to Hackensack Medical Center to get treated for myasthenia gravis. Alan had only spoken to the resident in the morning to tell him that the patient was believed to have myasthenia gravis, and the resident actually questioned him and told him what he thought it was, and which was true. The resident then was put on a helicopter, flew down to Trenton, where the state lab had botulism antitoxin, and he flew back by helicopter to Hackensack, and that was what actually happened. And then the postscript is that 21 years later, this guy, now an attending doctor, had lost his license in New Jersey because on weekends he was flying down to Florida to be the doctor to inject Botox for Botox parties. And it turned out that the New Jersey Medical Board heard about this. So that's the craziness that goes on in the ER. Here's another one. This is called Is Everyone Clear? It was a ghastly Friday afternoon. The phone lines scattered throughout the emergency room were ringing in a staggered, incessant, staccato succession. The ringing was accompanied by the sounds of pneumatic tubes whooshing and clunking as they transported their vital cargo of drugs, blood, and other bodily fluids between the ER and the vast multifarious network in the hospital's core. All the institution's beds were filled, and patients had been piling up in the ER for days. Every treatment slot was now holding two stretchers in a space normally allotted for one. Each of the local ambulance crews had been notified that it would be unsafe to bring us anyone new. Suddenly, during this madness, the medic radio sputtered and beeped. Park Ridge ambulance, Park Ridge, we're en route to your facility. Maggie, one of our savvy nursing aides, raced to the console. Though still in her early 20s, she already become seasoned and cynical. Scowling, she snapped into the handset. This ER is on bypass. I called you myself an hour ago. Park Ridge ambulance coming in with a 50-year-old male with chest pain, they continued. Don't bring him here, Maggie shot back. We're 2 minutes out from your location, they intoned, and then the radio went dead. 2 minutes was an exaggeration. Almost before Maggie slammed down the receiver, the ambulance doors whooshed open, and accompanied by the sounds of stretcher wheels clicking and walkie-talkies squawking, the crew rolled our new arrival in. Not having a defined place to go, they parked themselves and their charge in the middle of the ER's cramped open space between the nursing station and treatment slots. The patient they brought in was a gray-haired, overweight man, mid-50s, his long legs extending past the end of the gurney. Perspiration glistened on his pale, round face, and dark lines traced the V of a widening triangle of sweat across his white button-down dress shirt. While his eyes seemed calm and detached as they stared off into the distance, his sense of dread was evident in the tight set of his mouth and jaw as he lay braced against the back of the stretcher. I turned to get a sense of his condition and was struck with the thought that he seemed like an island of impending disaster in the middle of the ERC as nurses, lab techs, and wheelchaired patients eddied around him. Here's the guy with the chest pain. Vital signs are stable, the crew began. You're going to have to wait right there, the charge nurse growled, cutting them off, until we can figure out where to put him. So there they stayed, two self-conscious EMTs, shifting uneasily in their thick black leather utility boots, and their patient, hair now matted with sweat, eyes frantically darting around as he looked for any opening of the curtains that would reveal an available bed, a safe place to moor. Finally, a place was made for him on slot 6, and the ambulance crew gratefully wheeled him over. The nurse who ordinarily would have been overseeing this man was on bed 7, tending to a frightened, wheezing 4-year-old. So Maggie and I went to assist the two EMTs. I helped lift the patient onto the hospital gurney, taking the opportunity to look closer at him and feel for his pulse. It was not as strong as I would have liked. Maggie, despite years of EMT and ER experience, would never have been left alone with this man had there been any nurses available. As there were none, she reached into a drawer in the nightstand against the wall and handed the man a gown. I need you to lay down so I can do an EKG on you, she said, her voice uneasy. At that moment, I was pulled away by the conversation I heard on bed 7. Please, Josh, you need to keep that mask on your face, the nurse was saying. Her crisp, barely controlled tones told me that this child might be about to crash, and I strode to bed 7 as Maggie closed the curtain on bed 6 behind me. I'd barely had a chance to reassure myself that the asthmatic was relatively stable when Maggie screamed, Dr. Weinberg! I raced back to 6, tore open the curtain, and saw her bending over our new patient. He was now flat on his back, inert, not breathing. The EKG machine, its 12 gray electrical cables, and their red leads were now barely attached to the sweat on his chest, arms, and legs. Foot after foot of tracing paper was spewing from the side of the machine onto the floor. The lines being traced showed ventricular fibrillation, a pattern of erratic and random electrical activity corresponding to the random and ineffectual muscle twitching that was clearly occurring in our patient's heart. The only way to bring him back to life was to shock or defibrillating him. Where's the freaking code card? I yelled. Right behind you. I'm charging the defibrillator now, Maggie cried as she wheeled the cart in, while simultaneously shouting out, "There's a code on bed 6." The machine began the crescendo of its familiar high-pitched whine as I ripped the paddles from it. Applying them to his chest, I watched the electrical jewels on its red numbered display shoot up from 0 to 200 and heard the whine transformed into an incessant beeping, notifying us that it was ready to deliver its charge. I shouted to all involved, making sure that no one else would be hit by the shock I was about to administer. "Everybody clear!" I squeezed the buttons on the paddles. The jolt shot through him, and his large body convulsed, a huge wave cresting and crashing, the undulations flowing up to his head and then receding down to his feet. I turned to look at the monitor to see if he needed another shock. One of the nurses felt for a pulse. As I turned back to the patient, I watched as the first convulsion was abruptly followed by a second paroxysm, and then a third. I'd never seen this before, and I immediately sensed that we were witnessing a struggle occurring not just on a physical, but on a psychic plane as well, as if his soul was being torn between life on earth and the hereafter. The patient began moaning maniacally, his eyelids flickering before a lifeless gaze, as his massive body thrashed from side to side. The moan soared into a scream as his arms and legs shot out randomly in all directions. Maggie, the 5 other people from the cardiac arrest team, and I all pounced on him, grabbing any body part that we could to prevent him from flipping onto the floor. Now, locked in a furious struggle, we all were slammed against the metal bed rails, the mattress, and the wall behind him. As we tightened our grips, anticipating a protracted, brutal onslaught, his shrieking abruptly dropped to a whimper, and his writhing stopped. His eyelids opened, he took in deep breaths, and began to look around at all of us. Feeling him come fully back to life, the team slowly eased off. I allowed myself a deep breath, and all I could think was, my God, he was going into the white light, and we just snapped him back here like one of those red rubber balls attached by elastic string to a paddle. Within minutes, he began talking and acting like nothing had happened. And while this event had profoundly rattled me, the ER was so busy that I never had a chance to go back to talk with him about what he and the rest of us had just gone through. Instead, I immediately notified the cardiologist on call to admit him to the CCU, and we all plunged once more into myriad other tasks we've been doing before. The patient remained stable for the rest of my shift until he was transferred out of the ER, and I went home that night and recorded all the details of the event I could remember. About a year later, I ran into Maggie in the hospital. She had subsequently left the medical field and had come back to pay us a visit. I sat down to talk with her and told her I'd written a story in which she played a pivotal role. She gave me a curious smile, right eyebrow raised ever so slightly. "Do you remember one horrible busy Friday afternoon that you were working? A guy came into bed 6, you went to do an EKG on him and he went into cardiac arrest?" "Oh my God. Of course I remember," she paused. I'll never forget that day. As soon as I laid him down and put the leads on him to do his EKG, he stopped breathing. There was a nursing supervisor close by, and she told me to pound him on the chest to try to get his heart started again. Of course, it didn't do a damn thing, and that's when I screamed for you. I smiled, hearing her experience of the event. She stopped for a moment and then continued. "You know what that bastard said to me? After we resuscitated him and I was getting him into a gown, drying him off, completely freaked out about what had happened?" She looked at me for a response. I shook my head. So not only was he pissed that he thought my lying him flat had caused him to stop breathing, but he said, "I was on my way out, saw my body from above. I felt myself going somewhere so peaceful and calm after that hour of panic and pain, and you yanked me back." I thought again of that moment when it had been so clear to me that this man had come back from beyond. I remembered the drama, the abrupt change as his inert, flaccid body seemed to reinflate with life. I had thought, until Maggie and I had this conversation, that someone coming back from the dead would be ecstatic to be alive, so grateful and generous to those who had saved him. But at that moment, I realized that maybe it's just from this side of the great divide that we value life above all else. From the other side, it isn't like that at all. Maybe that's why he'd been so nasty to Maggie. Having seen what the Hindus call Maya or illusion from over there, he was angry at us, not only for killing him, but for bringing him back here as well. How are we doing with time? Are we okay?
Yeah, I think we're doing pretty good on time. Looks like it's 7:43 and we have until 8 o'clock. We've got about 17 minutes.
All right, should I read one last one?
I think so.
Okay. And I just
Ah,
have to tell people the name of this story is Schmeckel Down. And I know that Jordan will know that word, but in case anybody else doesn't, Yiddish has a lot of terms for penis. Um, Putz, schmuck, schwanz, I'm sure there are others. But schmeckel, and all of which have some negative connotations, but schmeckel is really like a cute kind of cutesy word, like you might say if you were at a bris and somebody gets circumcised and you go, oh, look at that cute schmeckel. So that's where the term schmeckel to me comes from. So this is called schmeckel down. It was the week of the High Holy Days. Not being an observant Jew, I found myself working both the Rosh Hashanah and now Yom Kippur shifts in the urgent care where I'd been employed for several years. The day was unfolding in a most unrighteous manner. Unlike a religiously ordained Day of Atonement spent among fellow congregants with services led by a rabbi, where I could ruminate on and try to expiate my sins, it had become instead a day of personal atonement and regret for my showing up to work at all on a Jewish holiday. I was the only physician at the site, and I had only one assistant to help deal with the overwhelming number of incoming patients. Plus, we'd walked in to find that there were inadequate medical supplies and no radiology technician to take any needed x-rays. Adding to my regret was the realization early in the shift that despite multiple phone calls, emails, and texts from me to the powers that be about our dire and dangerous situation, no help would be forthcoming. I was feeling a deep sense of abandonment, of being thrown to the wolves on this holiest of days. What a fool I was to decide to labor on Yom Kippur, I mused. Perhaps someone is trying to tell me something. Though I strongly self-identify as Jewish, I long ago realized the rituals in shul during the high holy days, rituals that for many are a reflective, cleansing experience, only leave me flat. When I'd submitted my schedule request the prior month, I hadn't given a thought about working on Rosh Hashanah or Yom Kippur and hadn't even realized what dates they were. As the nightmare of the day, toiling on the yam, as some people call it, unfolded, I was kicking myself, becoming more and more angered. Prescriptions weren't going through to the pharmacies. Patients were sicker, nastier, and more demanding than usual. I realized I was at least partly to blame, though, as I'd foolishly assumed when I'd walk in to start the 12-hour shift that day, it would be relatively slow. I'd expected that the largely Jewish population on the Upper West Side of Manhattan, where the urgent care is located, would be more focused on synagogue than sickness. Instead, we were exceptionally busy and nearly out of control. By 7 p.m., I was raw, drained, and having problems being my usual carrying, even jovial self. I was desperate for the shift to end. Fortunately, there was a lull at that moment, and I walked to the back of the facility in hopes of catching up on my charting so I could bolt out the door on time at 8 p.m. I was sitting in front of my computer, clicking nimbly as I signed off on my charts when I became aware of a new patient registering at the front desk. As I listened to the sound of his voice and heard what I sensed was the self-induced desperation of his circumstances, I was primed for aggravation when I walked in to see him. I trudged into the room and found him sitting casually on the examining table. His tattered shirt was partly open to reveal a mass of mangled, soiled tape and gauze dressings hanging off the left side of his chest and abdomen. He was a wizened, scruffy little bald-haired man of indeterminate age, though from his chart I quickly discovered he was in his mid-60s. He told me he was half Irish, Catholic, half Jewish, and lived deep in Brooklyn. As I stepped closer to him, he began revealing his story, explaining why he had felt forced to come all the way to our urgent care and informing me about his recent surgery to remove a testicular tumor. He bemoaned the episodic inadequate treatment he'd had since the procedure due to his being on Medicaid and his recent inability to get the right supplies to cover the wounds he'd occurred after a complicated operation gone wrong. His saga and the obvious inequities he'd suffer only added to my annoyance and frustration. Annoyance that was growing and showing as he disrobed entirely to reveal a surgical scar that extended from scrotum to nipple, taking up much of the left side of his groin and abdomen. At that point, I began to get an actual sense of what he'd been going through, and I also realized that properly caring for that wound was going to take me way past our 8 p.m. official closing time. Always the professional, though, I began formulating a plan for what had to be done. And as I pondered the situation, I found that in spite of myself, I was starting to warm to him. He watched me as I inspected his extensive cicatrix. And as I turned towards a cabinet to get the supplies I'd need, he asked, "How does it look, Doc?" "Could be a lot worse," I allowed. "Have you read any Shakespeare, Romeo and Juliet?" "Yes," I said, though I couldn't at that moment recall when. "Do you remember the dialogue between Mercutio and Romeo after Mercutio's been stabbed?" I had to admit I didn't. So he proceeded to recite it to me, verbatim, with a near perfect pitch English accent. "Romeo, courage, man, the hurt cannot be much." Mercutio, "No, 'tis not too deep, 'tis not so deep as a well, nor so wide as a church door, but 'tis enough, 'twill serve. Ask for me tomorrow, and you shall find me a grave man." With that, he had me. At that moment, he could have asked me for anything, and it would have been his. I hunkered down, assiduously cleaning the dirt from his wound, and then, even though we had none of the large yellow gauze dressings he needed, I began covering in a most patchwork manner his reddened raw scar, from a deformed scrotum past a contorted umbilicus and up to a mangled left nipple, with our own tiny oily pads. As I toiled, he soliloquized about his gigs as a stand-up comic, about his unorthodox religious and cultural upbringing, about his maniacal hatred for Trump. Ironically, listening to him talk as I performed one of the things most proscribed on this holiest of days, washing him, and feeling us bond while I scrupulously cared for the wounds, it was as if I was being given the chance to wash away my own transgressions from the past year. At one point, far into these ministrations, I had to lift up his post-surgical penis to clean what was left of the scrotum, then cover it with gauze. I needed his assistance when I completed that task. "Schmeckle down," I requested. He complied, and rearranging himself, his remaining testicle, and his schmeckle, he began riffing on what the down from a schmeckle, compared to, say, goose down, would be like. I'm not sure I can repeat, nor would care to the imagery he evoked as I continued the process of covering and taping down his dressings. I will say, though, that by the time I was done, having placed countless lubricated gauze squares over the left side of his groin and torso, covered them with dry dressings, and then secured them in place with yards and yards of tape, I found myself transformed. I vowed to go home and reread Romeo and Juliet, and I left that work that night feeling refreshed, uplifted, and absolved. As I walked home, I realized it was my own perfect Yom Kippur. Comments, thoughts, critiques?
Excellent. Thank you very much. I love that you talk about the doctor side of things, but also you were able to incorporate that humor and just that that way of telling the storytelling. So that was really great. Seeing some clapping happening as well before using the emojis.
Yes, I see that. That's very nice. Yeah.
So,
No, the humor was something that kept me, fairly sane. The Borscht Belt kind of humor. And I also wrote a piece that got me the blog on Psychology Today about the link between literature and art and medicine. Um, and I would sometimes, when I was in the ER at Bellevue, I would feel like I was in the middle of a Marx Brothers movie. Um, but that would make me laugh, and continue moving on. I don't know if people know the stateroom scene in A Night at the Opera, where all the people crowd into one room, and then finally the nurse or the cleaning lady comes to the door, and it's just mobbed. And Groucho opens the door, and she goes, "I'm here to clean up." And he goes, "Just the person I'm looking for." And there were so many times in the ER, kept looking for the person who could come in and clean up. So,
Awesome. It looks like we do have a hand up for a question, Felicia. You're welcome to turn on your mic, turn on your camera.
All right. Good evening, everyone. Dr. Weinberg, thank you for a very enjoyable reading. I actually laughed out loud when you were talking about the patient reciting the Shakespeare and you saying that you were his at that point. That made me laugh.
oh, that was it.
Yeah, I did not think I would learn a little Yiddish and hear some Shakespeare. What have you ever written a screenplay?
Yes.
Okay. What was that one about?
It's called Death in the ER, and I actually know a very well-known director. I sent it to him. He wasn't that interested, but another friend of mine did American Pastoral. Do you know that the Philip Roth book, and it was made into a movie? So he's a
Hmm.
producer, and I'm going to send it to him. But why do you ask? That's interesting that you asked that.
I mean, given your background in TV and film, um, I mean, not only you mean your education and you worked in the arena, so I would have figured that you would have went for a screenplay before a book.
Yeah, no, I wrote it years ago. Yeah, and I'm hoping maybe my friend Andre will pick it up. But it was fun to write, and it was actually based on another ER story that was just so crazy and so many ironies and synchronicity, which I talk about a lot in the book that happened with this. So yeah, that spurred me to write the screenplay.
And I had another question. Have you ever had a near-death experience yourself,
No. Nope.
or a mushroom experience that took you somewhere close to that?
I did psychedelics in college and a little bit after, but I don't remember a near death kind of thing. I'm actually
Okay.
a dear friend of mine does them here where I am in Columbia County with psilocybin, and I'm tempted again. Have you had those anything like that?
I mean, mine was kind of psychedelic. It was psychedelic, but it wasn't as psychedelic as I would have wanted to. I was really hoping to actually speak with some of my ancestors. I just saw like a white light, angelic type of woman in the ceiling pouring down white light. That's all I remember. But there was no conversation.
Which was that? What psychedelic did you do?
It's I felt and some variation of penis. I forgot exactly. Isn't there a penis mushroom? It was psilocybin.
Penis envy.
Yeah, yeah. It was
Oh,
that.
oh, really?
Yeah.
No, that was
I just don't like how cold I get. That's really hard for me to take.
yeah. No, but look, I mean, cannabis is a psychedelic also if you take enough of it,
Yeah.
you which I don't do, but yeah.
Because you've learned the hard way. Yes.
Well, thank you.
Oh, absolutely. No, thank you for your comments and so you read the book.
No, I haven't done. That's my first hearing of it. I was expecting to hear some stories about cannabis in it, actually.
One of the last chapters is about my years as a cannabis doc. I will just tell you one quick thing that from cannabis. I had a Hasidic patient with irritable bowel with IBD, and he was taking a high THC cannabis product and doing really, really well with it. And after a month or two, we had a follow-up, and he said to me, "Dr. Weinberg, does THC give you wisdom?" And I thought, wow, what
Mhm.
a great question. I said, "What do you mean?" He said, "Well, I've been reading Talmud all my life, And there are all these passages that I don't understand. And when I use my medical cannabis, I get it. They really are clear to me. And I talk to the rabbi and I talk to my wife. It's not that I'm high, I'm really seeing it. And I'm sure you got everybody who works in cannabis has probably had similar experiences. But I just love the fact that it was a Hasidic Jew who asked me about
Mhm.
giving wisdom.
Yeah, that's pretty amazing.
That's brilliant.
Dude.
Ken, I just want to jump in here and thank you so much for sharing with us this evening. This has been remarkable, both in terms of your reading and your artistry, and personally, really fascinating, because every one of your stories, I have a matching story from my years in the ER. And I guess it's just there's such commonality, whether it's the guy who you just put in the gurney and suddenly he's dead and you have to resuscitate him on the spot, or the abscess that explodes and covers you in the entire ceiling. It's never pretty, but it's always entertaining, or at least keeps you on your toes.
Oh, it certainly keeps you on your toes. Absolutely. And having said that, I'm so glad that I'm now being a cannabis doc and not in the ER anymore.
Yeah, yes, there was definitely a point for me too where I thought back and was like, I'm glad I did that. I don't think I could go anywhere near it again.
Oh, God, no.
The PTSD is real.
I was just going to say that, Jordan. Absolutely. And I think people who say that they don't get it from working in the ER are deluding themselves. I think it's impossible not to be in that mix every day or however many days a week, for all those hours,
Yeah.
seeing the things you see. And it's really thankless in a lot of ways. And then people disappear. So yeah, I finally acknowledged I definitely have PTSD from it.
Yeah. Well, I think medicine in general is a little brutal. But, we got to do it because we have to take care of people.
Yeah, no, if we're committed to that, absolutely.
Yeah. Well, thank you for putting voice and words to all of this trauma and experience.
Well, I really appreciate you asking me to do it, Jordan. It's so nice and my pleasure. I like reading my stories, and especially when people enjoy them. So,
Awesome.
okay. So I thank you again, and we should talk at some point. I have some interesting
Yes.
things to tell you that are going on. I'm sure you do as well. But anyway, thank you, everybody, and read my book.
Sounds
Yes,
like a plan.
definitely.
Great.
Thanks so
Thank
much.
you
I really
so much.
appreciate it.
Thank you, Dr. Weinberg.
Okay. Take care, guys.